Hi listeners, are you ready to elevate your skills in investigating psychological health and safety hazards? Our brand new 10-week Psychological Health and Safety Investigations program is designed for safety professionals and individuals looking to build confidence and capability in handling complex workplace incidents. Over 10 weeks, you'll dive into practical content, exploring how psychosocial hazards contribute to incidents like physical injuries, unsafe practices, workplace bullying, and more. With a focus on Australian laws, this program caters to both local and international audiences. Don't miss out. Enrol today for Cohort 1, starting 19th of September. Now, on to this week's episode.
From Flourish DX, this is the Psych Health and Safety podcast. With workplace mental health becoming a safety prerogative, this is the source of information on psychological injury prevention and health promotion.
Hi, and welcome to the Psych Health and Safety podcast. My name is Jason and I'm one of the hosts of the show. The aim of the podcast is to rapidly increase the knowledge and application of psychological health and safety in workplaces worldwide. To help with this, we have regular guests from around the world who are leading the way in this important area. But before I introduce our guest and topic for today, allow me to introduce my co-host, Joelle Mitchell. How are you today, Joelle?
Hi, Jason. I'm a little bit alarmed that it's September somehow.
Yeah. Father's Day always creeps up on me. I think it's because my wife's birthday is the week before Father's Day usually, so I'm more focused on that or remembering at the last minute. And I'm like, another year done, I remembered. And then at Father's Day, and then my birthday hits, and then end of year, pretty much. Melbourne Cup Day, everyone goes on holidays.
Everything stops after Melbourne Cup in Australia.
Yeah, pretty much. Yeah, between Melbourne Cup, which is the first Tuesday in November, through till Australia Day, which is the 26th of January, there's nothing that goes on. Like, what a lifestyle. It's great.
Yeah, we definitely aren't working frantically during those months.
Well, usually not. December was unusually very busy for us last year, but
it was, yeah.
We'll see what happens this year. Hey, but listen, we've got two guests on today, so I don't want to spend too much time chatting because I think we're going to need it all for the discussion today.
Sounds good.
All right, cool. So let's introduce our guests in. So Dr. Kevin Teoh is a senior lecturer and the program director of the Master of Science, Organisational Psychology at Birkbeck, University of London. He is also the executive officer for the European Academy of Occupational Health Psychology and his claim to fame, previous guest of the Psych Health and Safety podcast.
Most importantly.
Yeah. Andrew Cooper is head of programs and employee wellbeing at, this is something I should have checked, Aneurin.
Aneurin, Bevan.
I'm not even going to try.
Okay.
Bevan University Health Board. He is also honorary research associate at Swansea University. Welcome to you both, gents.
Always a pleasure.
So I'll start with you, Andrew. What podcasts do you like to listen to?
Oh, so really, current affair podcast, really kind of get the insight on political changes, discussion going on. So within the UK, the BBC put a podcast out called Newscast. So that's the one that I dip into most frequently to find out what's going on and getting different views and perspectives from it.
And Kevin, what are you listening to lately?
I think last time we spoke a lot about different sort of psych-related podcasts, and in a way, more recently, I've been focusing on other types of podcasts similar to Andrew. Current affairs, The Rest is Politics is something that I follow quite a bit, but alongside that, The British Scandal, which is a podcast exploring all sorts of scandals related to the UK, both in terms of politics but also celebrities and sports, and it's quite fascinating really about people, dynamics, power.
Yeah, certainly lots of current affairs happening currently.
Yeah, and generally covered pretty well by tabloids in the UK too, right? All of these scandals.
Yeah, but I think tabloids do it at a much more superficial level, and I think with podcasts, when you get sometimes 2 or 3 episodes, you can really unpack what's happening over within that context and behind the headline.
You get into the nuance of what's happening rather than just what's scandalous about it.
So certainly getting different voices in it as well. So those different perspectives are really helpful rather than just perhaps a tabloid perspective.
Yeah, more than just gratuitous, half nude shots, that kind of thing. Yeah.
Yeah, and that's why when it comes to podcasts, it's purely audio. and we haven't got the tabloid shots, and I guess you're not having a tabloid newspaper version of a podcast, so you haven't got to put our faces somewhere for people to look at.
Don't worry, we'll put it on LinkedIn.
So Andrew, can you tell us a little bit about your professional career, please?
Yes, certainly. So my background's really been communications and marketing for the last 20 to 30 years. I've been involved in quite a number of behavioural change campaigns, certainly working within public health, patient safety, quality improvement, and really that kind of focus on how do we help change people's behaviours around either health interventions or even work practice. So not a psychological background, but just the way that communications and marketing really plays into supporting those areas of change. And then more recently, I've moved into the wellbeing area of work. So a bit of a shift from 20, 30 years of marketing.
It's good to have you on the podcast to talk about that, Andrew, because we do get people with sort of all different backgrounds reaching out to us and saying, well, how do I work in this field? Do I need to go back and study psychology or something like that? And I think, where we do have guests like yourself with that different background, really showing what are the transferable skills, and actually, this is a transdisciplinary endeavor that we're undertaking here, and it really does take a lot of different skill sets to do it well, and certainly marketing and communications is such a critical aspect of any type of a change process, either within an organization or within any sort of a community or society. So thanks for coming and bringing your perspective. And Kevin, what have you been up to since we last chatted with you?
Well, so I guess my background is primarily in psychology, organizational psychology. I'm interested in the workplace environment, workplace systems, and that still is the case. A lot more in the last couple of years I've been focusing in terms of interventions, so looking at actually, we know the data, the evidence around why we should be looking at creating healthier, better working environments. The challenge is, how do we do that? So in the last year we've been looking at studying case studies of where people have tried to do this, to understand what works, what doesn't work, and actually to show that it is possible. Because often people say, yeah, it sounds great, reduce demands, increase resources, but it's not possible. And actually our counter argument to that, it is. And we found examples where that's been the case, and we're exploring and understanding much better how we can carry out these types of organizational interventions. And what we're going to talk about today is a great project which I've had the privilege of being part of, which Andrew led in this hospital organization.
Yeah, and intervention research, especially when you're looking at that sort of primary intervention as your research subject, is so important, right? To actually be able to show practitioners and organizations what you can do outside of a focus on individual health.
Yeah, very much so. And I'm not knocking individual interventions at all. I think they have a role to play, but they can't be the only thing that organizations or individuals are doing, and that responsibility has to go back to the organization to recognize how we structure, how we create, how we organize systems, processes, practices, policies, has an impact on individuals, both in terms of supporting them, or actually in many instances, as I'm sure we'll talk about today, harm individuals as well. And therefore there is the onus and there's the responsibility for organizations to take notice and to create change. And from a European or UK perspective, it's very much, I guess, on one hand, an ethical argument, a moral argument, depending where you are in Europe, a legal argument as well. And my understanding in Australia is there's also a legal argument that you have to actually take charge and do something around that. So just to say, yep, go sign up for some, download an app or go and attend this training session, that's not gonna resolve the issue if the underlying issue is the organization.
Yep, we're talking from the same hymn book, singing from the same hymn book, whatever
Hymn
the phrase
sheet, I
is.
think it is.
Hymn sheet, yes. Anyway.
Yeah, we don't talk from that. We definitely sing from that. But it sounds
maybe
like
some people should talk. But.
Yeah. Kevin, yeah, definitely me. I'm tone deaf. But yeah, it sounds like you are willing to knock individual level interventions, and your colleague over at Cambridge University, who recently did his PhD, William Fleming, he's been very vocal about the limitations as well. Actually, you might know William, but we'd love to get him on the podcast sometime. I have reached out to him. He has ghosted me.
Yeah, Will's done some really good work. I don't know him personally. I've spoken to him at events before, but I refer to his work a lot because it's a really good project. And I think maybe we'll just leave that as a teaser for people to go and explore, and pressure for you, Jason and Joelle, to try and track him down.
Well, we have been saying for 3.5 years that we want to get Adam Grant on the podcast, and we've finally secured the man. So he'll be speaking at our conference. We're going to be doing a live podcast recording with him in June. So, hey, if we can get Adam Grant, surely we can get Will Fleming on. So we'll have a crack at that. But both of you are involved in lots of different research projects. So it'd be good to get a sense from you both about, what are kind of like your main areas of focus before we go on to this specific research project that you worked on together. So maybe over to you first, Andrew.
So in terms of research, we've been looking at really a massive gap within the literature around the impact of the application of disciplinary processes through the employee investigation. If you think that thousands of investigations take place every day across the world, we just completed a rapid evidence review to identify what does a good investigation look like, how can it be run well, and actually there's very little in the literature. So really kind of there's almost a lacking curiosity of how to develop good policy, how to deliver good policy, how to consider the impact of the process on individuals being put through it. So in terms of that research focus, we really need to understand much better what those impacts, we've talked about them as harms, but also impact on organisations too. So in terms of the research focus that I've been working on with colleagues is how do we understand this better to inform interventions better? And then actually, certainly within the HR profession, there's a major focus on people first, people-centric policies. How do we make sure that's working into the disciplinary policy, which is often one of the most damaging policies that can be applied within an organisation, and yet we don't really have the background or the insight or the research to truly understand how to do it better.
Yeah, I'm really looking forward to unpacking that with the two of you today. Kevin, I know you have a very broad kind of area that you focus on, or was many different topics, right, that you touch on in your own research?
Yeah, so broadly it's workplace wellbeing, and looking at it from a systems perspective. So on one hand, we've got projects looking at exploring the impact of sort of the wider ecosystem on the individual, and that's everything from working conditions in the healthcare sector. We've finished a project earlier this year looking at actually the performing arts sector and the role of precarious work, and also parental and caring responsibility and how that intersects on individuals in the performing arts, and that's a very underexplored group of individuals. But as I said earlier on, a big focus in terms of interventions. If I just pick out one project last year, we got some funding to look at organizational interventions in the NHS, the National Health Service. And as part of that project, actually one of the drivers of that project was this whole notion that people say in the healthcare sector, there are no resources and demands are incredibly high. So it's not possible, or it's way too difficult to try and create change. And actually what we wanted to do was to counter that argument. And what we did was we put together, in the end, 20 interventions, which we summarize in a report. You can have a look at 10 of them, where we unpack that in more detail in terms of what they've done. And they were everything from small individual projects at a team level, things like changing how meetings are carried out, all the way up to large-scale organizational interventions to look at implementation of flexible work. But the idea behind that is to say, look, change is possible, and whether that's at a local level or whether that's at a larger organizational level, that to encourage people to try and change, but also to summarize and to learn across these interventions what worked, what didn't work, what are some of the principles that we can take on board. Because at the end of the day, one of the outcomes also that we picked out on is what works in one place isn't going to work in another place. And even one intervention which worked in one organization was actually the source of problems in another organization as well. So it's not just about copying and pasting, but actually really understanding what's the context, what's the issue, what are the solutions that are unique to our situation, and what can we do about it? Because there are things that we can do about it, but equally I'm not going to promise and say that we're going to fix everything. I think my perspective is that we can start the conversation, we can start creating change, and what we are looking to do is to create a better working environment today than it was yesterday, and kind of use that as gradual steps. It's not going to be a major overhaul that we're going to fix everything overnight or over the course of 6 months or even a year, but that change is progress, it's continuous, and that we have to keep going.
We're definitely singing from the same hymn sheet there, Kevin. So we love having you on. These are the constant conversations that we're having with clients and companies in this space. You know, even just today, Joelle and I were on a call with a client, and they're saying, hey, there's this group of workers, there's a real issue here, and these are all the reasons why it's very difficult to work or make any changes in this group. So they're already putting up the barriers, saying it's too hard to change. Whereas, like you said, when you actually think about it, you can actually come up with many different things, ranging from like small, low-hanging fruit to large systems changes. But if you go in with the mindset that it's too difficult, you know, you're really stopping yourself from actually doing anything that's going to make an improvement. So, yeah, good to see that you came up with not just one, but 20 in healthcare, which you like you say, is such a, you know, they're pretty far behind. Like you say, there's not a lot of resources, a lot of demands, and people are just willing to live with it for the most part by the sounds of it.
The project that we're here to talk about today is to do with avoidable employee harm. So first off, can we start with what we mean when we say avoidable employee harm?
Certainly. So we came up with the term avoidable employee harm within our health organisation within NHS Wales when we started a piece of work to look at the overuse and sometimes the misapplication of the disciplinary policy within the organisation. And we, I guess, started a journey of understanding around it, that we started looking at the potential impacts, and we identified 4 main impacts of the disciplinary policy. The first one was the potential impact to the individual being taken through it, the psychological harm, the reputational harm, how this is going to affect their future lives and careers. And that was almost our starting point. What is this doing to the person at the centre? But actually, as we explored further, we recognise that the disciplinary process through the investigation almost impacted everybody who was involved in it. So we've recently done a piece of work looking at the harm to the investigators and to colleagues who lead investigations. They often tell us we are harmed by this process. It's potentially one of the worst parts of the job. So I guess that was the first kind of major impact. The second impact we looked at was on organisational culture. That actually when processes like disciplinary policies are applied and are seen as being unfair or incredibly formal for addressing small issues, that actually psychological safety within the organisation is harmed, so that colleagues no longer perhaps feel that they can take the helpful, good quality risks to take things forward, and certainly within healthcare, taking risks to ensure that the best care is provided. So there was an impact to organisational culture. I talked to one colleague who from OD who'd been asked to go into a team where there'd been a number of problems. And she reported back to me saying, I could track the problems with that team all the way back to a disciplinary process that had taken place 3 or 4 years earlier, and the way that it had actually ruptured relationships within the team. So we start seeing the impact there. We worked with a health economist and started breaking down the costs, the financial cost of an investigation. We worked out before we introduced our intervention that the average cost of a start in the disciplinary process on an individual was £20,000, and that cost is without tribunal costs, without legal fees. And the health economist then said to us, but actually, Andrew, that's small fry compared to the economic harm that it can do to organisations, particularly in the place we've got a major issue with retention and recruitment within the NHS. If we are seen to be using policies that are harmful, that are far too formal to address issues, that doesn't create a great work environment that people want to work. And then the fourth area that we're actually just starting to look into, but with these processes, sometimes staff are suspended. Often they will go on sick leave because of the psychological trauma involved within it. What does that do to continuity and consistency of care being delivered to our patients? So that was a bit of the map that we were looking at, and then started considering actually learning from the patient safety movement, which was established 30, 40 years ago, where they actually recognised that they were causing harm to patients that was avoidable. We started to ask the question, is there anything about our employee practices, our HR policies, that is causing harm that's avoidable? So that's where the term avoidable employee harm came from, and certainly helped shape the conversation around this programme of work.
Yeah, so I would imagine there's quite a bit of moral injury that goes on, especially for like a manager who's been instructed to conduct a performance investigation or a performance management process where they maybe don't feel that that's appropriate or necessary. Are there other types of relationships that we see between systems of work and harm?
So in terms of the avoidable employee harm model, we've been looking to apply it to other areas, certainly within policy. So every time we do organisational change, we know that that can cause significant harm to individuals and the system. And it's almost as if often we lurch forward with doing the change without considering what those impacts are. So actually how organisational takes place in terms of whether it takes place too quickly or too slowly has a major impact on individuals going through it. And often those considerations aren't part of the organisational change plan. And then as a result, organisations are almost reaping that whirlwind years later in terms of not seeing the levels of productivity, not seeing the levels of engagement from staff, simply because a consideration of the harm that the process does wasn't built into the original planning. So I guess we've been really working with colleagues and encouraging them to look at the application of processes and policies through that avoidable harm lens.
Yeah, and it's definitely, I think, an interesting lens to apply there, and probably a way of framing it that's maybe a little bit more understandable to, I guess, your sort of your leadership and executive types of roles in organizations, maybe more so than talking about psychological injury or something like that maybe feels a bit more loaded.
Possibly, but just to say, there was a reluctance from senior colleagues around the concept of avoidable employee harm. What? We can't say that we're causing harm to our employees. And actually, that was part of the change in conversation. I remember one HR colleague saying to me, I really don't like the way that you're telling us that we're causing harm to our staff. And for me, that kind of suggested that possibly that hadn't crossed their mind before. So actually, how do we get colleagues to think differently? But I guess leaning and learning from the patient safety movement, I was able to say this isn't personal. Healthcare professionals over the last number of decades have acknowledged that they needed to look at their own policies and processes and some of their long held beliefs and recognize, no, we need to do this differently. And sometimes you need a language, you need a new language to kind of shape that conversation. And I think that's what we're seeing around avoidable employee harm. It's a new concept, it's a new term that we'd really like to see enter management, HR, kind of employee engagement in the same way the avoidable patient harm language entered healthcare systems.
If I can just come in here and kind of build on what Andrew was just saying, I think there's lots of parallels which what Andrew and team started working on with what we've been talking about, that wider ecosystem and its impact on individuals. Because as I said earlier on, how we design, organize, structure workplaces impacts on the health and well-being of individuals. And I think there is a danger in many organizations that we are putting in place policies and procedures, sometimes actually with the intention of helping individuals, but not recognizing what impact that actually has on individuals and people within the organization, and therefore by default the wider organization as well. And Andrew talked about employee investigations, but we can look at other settings as well. And for example, when it comes to flexible work, I've had conversations with line managers or middle managers who are saying our organization's pivoting towards a flexible work policy. We're supposed to be encouraging individuals to work flexibly, but you've got individuals then coming to me saying, I want to work flexibly, but I can't let them do that because I haven't got the resources to allow them to do that. And then when I deny them, I'm the bad guy because the individual says, well, you're not living up to your organizational values. And then I get pressure from senior management to go, actually, why aren't we putting this into place? So you're caught between a rock and a hard place. And I think that's what's so powerful about the work which Andrew and team started, which is actually kind of providing that language, providing that framework and that perspective to say, look, this is potentially an issue. And not only leave it at that, but actually to go on, we have to do something about this. And now at this point to say we've done something about this and we've demonstrated that actually it can work to try and change something.
Do you need more psych health and safety in your life? Then head over to the FlourishDX Academy for several free on-demand e-learning courses. If you're an internal professional, follow FlourishDX on Eventbrite to register for any of our free fortnightly interactive webinars. Our flagship professional practice program is also exclusively available for internal professionals. The 12-week course blends theory, applied practice, and interaction with other professionals through live lectures and a monthly community of practice session. Find out more about all these learning opportunities or inquire about a bespoke in-house training at the FlourishDX Academy. www.45003.org. Now back to this episode. So I guess with that in mind, what were the main drivers for this particular research project?
So if I could take you back to where we were within our health organisation a number of years ago, so I mentioned that I work within the employee wellbeing team. We run a counselling service for staff within the organisation, and we'd seen an increase in the number of referrals coming through from staff that were being taken through employee investigations and really facing major distress and anxiety as a result of the process. And then at the same time, in another side of the business, our HR team had conducted a review of investigations that we'd run over a period of time. And they'd worked out that over 50% of those investigations had led to no sanction, so that actually a formal process had been started, an individual had been taken through what we now recognise as a highly traumatic process and had led to no sanction. And I guess that's where it left us thinking, are we getting this wrong somewhere to be putting staff through formal processes that are not leading anywhere? Now we recognise that this has never been about removing workplace investigations or disciplinary policies from organisations. They clearly have a place to address issues. I think what we've recognised within our organisation, but certainly as I talk to NHS organisations across the UK, we do have a propensity to push the button far too quickly on starting a formal process. So for us, that was the starting point for the piece of work. I think you're going to be playing Anne's story into this podcast, and Anne's story really shows the impact on lots of levels that the process has in terms of waste to the system, in terms of the cost to the system, and then the individual cost as well. So that was the starting point for the work. We wanted to build an intervention that would help bring down the number of avoidable investigations in the organisation. And that's the intervention we developed. But I'm going to pass over to Kevin, who's kind of been helpfully guiding us through the research piece around it.
I think just building on the work which Andrew and team started off with, coming from a more academic perspective, is recognizing that actually we talk a lot about how we have to change or how we need to take an organizational perspective. The question is, how do we do that? And the groundwork that's been set up over here actually provides a framework that we can look at. A real life case study where an organization and an excellent group of people have attempted to do that, and that's clearly a gap, because we in general, we publish very little in terms of interventions, particularly at an organizational level within the academic literature. And if we aren't exploring this from an academic perspective, well, how are we then facilitating knowledge, learning and development, both in academia, but also outside as well? And so that's where we saw that there definitely was a gap, that we had to capture this somehow, both in terms of its learning, but also in terms of its outcomes, and to try and write it up in a way that we could then disseminate this and further, to share the good work that's being done over here, because otherwise it's just going to be a hole that we have, and that is concerning, because no one's going to be learning about how we can do things better or differently, or as with sometimes many terminology and sometimes academic concepts and theories, it remains that it's a theory. It sounds great on paper, but actually what we don't have is proof of concept. And that's something that we really wanted to work on, was through this intervention, demonstrate proof of concept that we can do something about this.
Yeah, it's great to hear about the drivers and hearing from the lived experience, right, of people within the system that can see the system is clearly broken, the implications for both, I guess, productivity as well as the health of people who are going through disciplinary processes as well. So with that in mind, it's probably a good idea to cut that story in right now so that people can listen to Anna's perspective.
And story, yeah. That's
And
right.
story, yeah. So we're cutting to that right now.
Anne had worked with the NHS since she was 18 as a nurse and midwife. Over 37 years, she had held various roles, including running busy labour wards and supporting staff as they looked after expectant mums-to-be. She loved her job, and in speaking to her, you quickly realise that it was much more than a job. She had poured her life and a commitment to caring for others into it. She had planned to provide many more years of service, but a query over her revalidation, which should have been easily addressed, quickly spiralled into the worst experience of her working life. It led to an internal employee investigation and referral to her professional body, in which she was alleged to have committed serious misconduct by failing to follow the correct process. Over the course of 15 months, an internal process and external feedback from her professional body eventually concluded that there was no case to answer. The organisation's HR team even acknowledged that its formal disciplinary policy should never have been used to address the issue. However, the damage had been done. Anne spoke about how the process and the way she had been treated had made her feel like a criminal. She felt isolated and unsupported by both her organisation and professional body, and suffered from chronic anxiety at the thought of returning to work at the end of the investigation. The experience had broken her. While she hadn't intended to take early retirement, she felt that it was the only option left open to her, bringing her NHS career to a painful and wasteful end. She observed, "To this day, I'm still not sure what it was all about. I'm not sure what I had done wrong or what they were trying to achieve by putting me through the process." Sadly, this was a case of employee harm which could have been avoided.
So tell us about the intervention that you designed, please.
Okay, so I guess it was a bundle of interventions. So we've just listened to Anne's story. We've recognised that actually we were overusing the disciplinary policy within the organisation, putting many of the kind of the wrong cases through the process. So we developed, I guess, a series of interventions. The first one was at across the organisation from the perspective of our executive team within the organisation. So we had senior buy-in. We agreed that we would take a last resort approach to using the disciplinary policy. Now that was quite significant in the sense to address that overuse that we wanted to be saying to our managers, to our HR team. Whilst there is a place for applying the investigation process as part of the disciplinary policy, actually we need to be looking to see whether there are more informal approaches we can take before we get to that point. So that was part of the cultural change that we were looking to make. How do we help our staff not press that button straight off, but think about how can we do this differently? Does this really need to go through a formal process? Are there other ways in which we can manage this process? And I guess that was really supported by, certainly from a practical side, we have an initial assessment document that we use within the organisation. And that initial assessment we revised as part of this programme of work. So what happens with that document? Managers use that to complete details of the issue, the presenting issue, to decide whether to take an investigation process forward. What we did with the revised version was we focused on more wider issues than just the presenting issue or error that had been raised. We kind of looked at what was the surrounding context, what was going on at the time when that error was made. Who is the individual sitting in front of us? How long have they worked in the organisation? Have they had their induction completed? What's their history within the organisation? So it was very much more about understanding and having a wider picture rather than just focusing on the issue. So from a top level perspective, the focus on the last resort was important. But equally, how do you turn that into practical outworking? That initial assessment documentation was key. And we certainly discovered as we took the intervention forward, that played a key role in terms of the decisions that were being made. So we had one division that had a high number of investigations historically taken place there. And we talked to the manager, and as a result of training that they'd attended and the use of the initial assessments, they were able to downgrade a number of the investigations that they'd initiated, and it certainly changed their approach and decision making for going forward. So I would say those are the two key areas. The focus on avoidable employee harm that we've talked about was equally important, because actually that was the conversation we were seeking to engender with our staff. This is not just a process. This is not just application of policy. We need to consider the harm that it's going to do. And if it's not necessary, let's avoid that harm.
Yeah, so it really sounds like sort of applying a human factors lens to sort of the situation. What were the performance shaping factors that were going on there as well, in and around the actual behaviour that was flagged, I guess, as being a problem. So, yeah, some sounds like some very useful interventions there.
I think as well, the biggest one was understanding culturally and historically why managers and colleagues kept reaching for that formal process to be taken. So actually, we know within the NHS there can be a lot of fear, and even managers think the best way to address is by taking the formal approach, that it covers them in terms of addressing an issue. And actually part of this work was actually encouraging them to think, no, how could you do it differently? How could you do it better? But it was really about understanding the cultural context and also where managers are in terms of what was leading them to make those decisions.
Yeah, that makes me think about like Rob Briner talks about HR theatre. And it almost sounds a little bit sort of a similar concept there, where the managers might feel like they need to be seen to be doing something, and certainly from a public interest perspective as well, that they need to be seen to be taking action, and maybe this is the only action that they know how to take.
So absolutely, when we work with our teams, one of the key things was promoting alternative options. So I had a number of managers say to me, "Oh, I thought the disciplinary process was the only option open to us." So clearly, how do we communicate to colleagues that there are other options, starting with a cup of coffee and an informal conversation to work out kind of where things are, and then there were a number of options in between, kind of pressing that formal button. So absolutely really key to understand what was shaping managers' behaviours in this.
just adding and building on what Andrew was saying, I think it's important to emphasize that actually we're talking about a bundle of interventions, lots of things coming together. When we were writing up this for to publish one of the earlier drafts, the reviewers came back and said, isn't this just like a training workshop? Because that's part of what we did. So we talk about training workshop and we kind of evaluate it before and after. But actually we knew, but we had realized we had to communicate it much more clearly. That actually was a lot more than just that. It wasn't just a case of getting some key stakeholders together, getting them together for a day. Here's a training workshop and off you go. Because if you want to have that culture change, it really is looking at that systems perspective and the work that was part of this intervention alongside sort of cross-team training events. There was the work done in terms of executive engagement and support. There's coaching and influencing going around to encourage managers, as Andrew said, to consider alternative routes, facilitating collaboration between HR and employee well-being teams, and also engaging stakeholders across the board, whether that's senior management, trade union, and other areas of the organization as well. And kind of going back to the top of this podcast where we talk about the importance of having individuals from different backgrounds, I think sometimes for psychologists or individuals in a well-being space, one can feel quite protected to say, actually, this is our space and others shouldn't come in and almost gatekeep that. But actually, we should open that door and open those conversations, because if we are talking about culture change, we have to involve colleagues who are working across the business, colleagues who've got all sorts of specialties, because otherwise we're doomed to fail. And we might just end up with a training workshop, which might be great for the people who attended on the day, but are they going to put that into practice? Will that actually change behavior? And the answer is no, if you haven't got all of the other work that is going on as part of this process.
Yeah, it's great to hear that evidence-based practice in action. So many times people are looking for a intervention off the shelf or a training program, like you say, Kevin, that's, just there. Let's just get it off the shelf. Let's apply it and then just assume that it's worked. So it's great to hear like the depths that you went to with the team to really investigate from many different perspectives, what is actually the issue here? What are the maybe upstream factors that are influencing behavior? Or, like you say, managers to press the button on the formal approach. And then how do we go about changing it, considering all the factors, rather than just educating people around when do you use a disciplinary process, when don't you? So, great to hear about that in action. I made a very similar comment actually on a webinar recently where there is a real push, it feels, for line managers to be sheep dipped through training on psychosocial risk management and what can they do around, or what's their role in psychosocial risk management within an organisation, without the organisation first actually having systems and processes and tools to support the leaders to do their job in this space. And so I said, do not go and train people until you have all those other things sorted first, because otherwise you're just wasting your time. And in fact, you're going to probably lead to a lot of leaders burning out because you're asking to do something else and they're not supported to do it.
Yeah, and I think that's sometimes that tokenistic aspect of the organization saying we're going to do something, and the easiest thing is, well, bring in a training provider to offer something, or an online training modules or series of them, and then you do them, and that's fine because you know what to do, and then you go about doing it. And if I just bring an example from a different case study, and that looked at fatigue, and they had psychoeducation trainer coming in to talk about the importance of rest and power naps, getting enough sleep. But one of the things they also looked at it from a culture change perspective. And one of the things they realized was that the head midwife, who basically said, "My midwives don't get tired." And if you have that value or that perspective embedded within senior leaders, no midwife in that team is going to go, "I'm going to go take a break because I'm tired, because my training module told me to go and do that." If I know that my senior midwife is going to look at me and think I'm weak. So that is basically a sticky plaster approach. And what's great about that intervention is actually they looked at it again at a systems perspective to say we need to change that perspective that some of our leaders hold, because otherwise behavior will not change.
Yeah. Look, I got many anecdotes, so I don't want to derail this podcast any further in the fatigue space, given that's where I cut my teeth on human factors. I am interested, though, obviously, like you say, it's a bundle of interventions here, but I'm interested in how you measured the impacts of the intervention and what were some of the key findings.
Should I come in here? I think what we want to do was to look at it across different aspects, different types of outcomes. So to start off with was firstly, actually, was there an awareness of change? So knowledge change within the organization. One of the ways we looked at it is we surveyed participants who did take part in the training sessions before and after in terms of their understanding of this concept of avoidable employee harm. And what we learned was that, yes, going through the workshops, going through this process, it did significantly improve participants' knowledge about the process around an investigation. It improved their understanding of how investigations can impact an individual, and that was really important. And then actually, it also improved participants' awareness of how to avoid such harm. So as a starting point, that's really important, because actually what we're realizing is individuals learn that the investigation process is harmful, and therefore something needs to be done on the back of that. The big question, though, is actually, does this lead to behavior change? And Andrew already mentioned examples where people have changed their practices, and there are lots of anecdotal evidence of that. But fundamentally, from an organization perspective, is, do the statistics, do the numbers change? And over a 1-year period, what we learned was actually that there was a 71% reduction in the number of cases that we went through that process. So an average, it's just over 4 cases a month, and that went down to 1.23 cases a month. So that's about 3 cases a month that are being saved. Over the course of the year, 35 fewer cases, which might not sound like a lot, but that's 35 individuals who are not having to go through what is a very distressing process. But on top of that, from an organizational perspective, because really we know that the ethical argument, the moral argument should suffice, but organizations often are thinking, actually, what's the impact on us as a wider organization? So in terms of quantifying that, in terms of sickness absence, from those cases, we extrapolated that's 3,300 sick days that the organization saved. So if we think about the impact on care, and particularly in the UK, there's significant concern around lack of staffing levels, high sickness absence rates. So 3,300 sick days is a lot of days that are being saved. And the impact that has on individual morale, but also on continuity of care, is also quite significant. On top of that is then actually saying, can we quantify this from a financial perspective? And the short answer is yes. So when we looked at the direct savings associated with the reduction of this 70% reduction of cases, we actually saw over £700,000 saved by the organization in this 1-year period. And that's in terms of the direct savings, so backfill costs, so medical treatments of employees, but also other cost saves such as administration. But in a nutshell, that's, I think, some of the headline findings, because not only are we demonstrating changes in terms of individuals' awareness, or actually awareness across the organization because it's lots of individuals, but also there's that behavioral change in terms of, yes, number of cases have gone down, but also then correspondingly the savings to do with sickness absence and money.
Yeah, I agree with you, and I'd love it if the moral argument sufficed on its own right. But at the end of the day, the thing that really grabs the CEO and the CFO's attention generally is the dollar figure, the bottom line. And like you say, 3,300, wasn't it, days saved by having 71% less investigations. Um, in many industries, people don't really see sickness absence as a direct cost because they're paying a salary regardless of whether someone comes to work or not. But obviously in healthcare, you can't operate with like less people in a surgery room or, nurses on the floor. So there is backfill that you have to pay for, right? So it is actually a real cost when we're talking about sickness absence in that case.
There is as well, from a safety perspective that I mentioned earlier, what does that do for care being delivered? So in terms of consistency of care, do you have the people that understand perhaps the patient's journey, and that expertise is also lost for the periods that colleagues are off. So you're absolutely right in terms of it's a real loss, but it's a potential harm, additional harm to patients as well. I think as well in terms of the impact of the intervention on a Wales level. So actually we delivered this for a 13-month period, and then our Welsh ambulance service got in touch and said, oh, could we come along and see what you're doing? Because we've got an issue around this and we'd like to kind of learn. And it was great actually to learn from them as well, but they've just reported a 60% reduction in the number of their investigations. And then we were able to work with the workforce body for NHS Wales, which is known as Health, Education and Improvement Wales. And now we're scaling this programme up across NHS Wales for other organisations. But it's interesting picking that comment up earlier around doesn't just mean it doesn't necessarily mean that it works in one organisation, and the work that needs to be done to tailor it, so to really understand different organisational needs. They might not be the same as the Aneurin Bevan where we started this piece of work. So actually we spend time looking at different organisations' data. What is the data telling us about the investigations they currently run? What is the culture? What does the culture look like in terms of how these processes are run? So really seeking to take some of this initial learning and those interventions that we discussed, but actually apply them in a much more specific way to the organisation that we're working with. And the other thing that it's enabled us to do within NHS Wales, we employ, I think, 90,000, 100,000 staff, so it's the biggest employer within NHS Wales. And we've got an all Wales disciplinary policy. So whilst we might have different organisations making up NHS Wales, actually there's one policy that sits across all those organisations. What this work has enabled us to do is, with that review, is to feed some of the findings, some of the insights into this review of the policy. And some of that is, how do we make it more people-centric? How do we carry that last resort approach in? How do we look after managers who deliver this? And perhaps one of the things that that has come out of this, that we've just written a disciplinary guide to an investigation for the individual, because actually often what happens, the formal letter comes out of the organisation, scares people half to death because it's incredibly legally worded and legally framed. That starts the journey of stress, trauma and anxiety of the process. So we actually wrote a guide that's written with the employee in mind, so that it brings some of this learning together, helps them understand a bit more about what the process is they're being taken through, and then actually hopefully reduces some of the stress and anxiety by answering some of those questions, but also potentially puts them in a better place to contribute to the investigation. So I guess we've been on a journey with this piece of work, starting with one pilot site, looking at working with organisations across the NHS Wales service, but then actually then taking it to a point that it impacts and affects policy, so that future policy application acknowledges the harm and hopefully helps colleagues deliver it in a more compassionate way, as well as ensuring the process is followed correctly.
Yeah, that's amazing to hear the scale up, right? Did I hear that right? 200,000 employees across NHS Wales?
No, 100,000.
100,000.
So you just added 100k there.
I do that often. What's 100k between friends? Hey, but what was the size of the pilot site, Andrew?
So the pilot site was 16,000 staff. So our organisation employs 16,000 people for serving a population of 660,000 people within South East Wales.
Yeah, so I mean, you're talking about direct benefits for the employees, right? And if you go from that pilot site up to NHS Wales, then you're talking about 6 times potentially the impact, right, on direct employees. But then obviously, I was going to say the quality of the intervention might not be as good given the larger scale, but still, if that other site or that other organisation was able to see a 60% reduction in investigations versus your 71%, hey, maybe you get at least 50%.
Well, and to be honest, to be fair, other organisations might not have as big an issue as the one that we did. So, also need to take that on board. But culturally, in terms of the focus on avoidable employee harm, it is giving organisations a new language to apply across policy delivery, not just the disciplinary one. So actually, how in the same way that the patient safety movement really inspired healthcare professionals to look at a number of areas that they were causing harm and to build interventions to address them. So if this kick-starts a wider conversation around avoidable employee harm, in terms of how the workforce is supported, that will be another kind of bonus from it.
Yeah, and this is why we need a transdisciplinary approach, need that comms and marketing brain, Andrew, to come up with terms like this that resonate and get people to take it seriously. I might try that one. We've been discussing internally, like I think health and safety get the language that we use like on this podcast, but sometimes we don't get the same cut through with HR. So maybe it's something to test out with that audience regarding, their use of policies and a lot of the systems that they own within work. One question I do have for you as a follow-up regarding patient safety. From my work with healthcare, that seems to be the number one thing, right? That is the thing that they are most concerned about, patient safety. How do you measure that? I'm assuming, because you didn't talk about a measure of patient safety or an improvement with the continuity of care with reduced illness absence, is there a way to measure that in healthcare so that we can get some of that additional impact beyond the employee to the people that they're servicing in the community?
So we cited research, not directly related to this project, but just research in terms of if staff and when staff do go on long periods of sick leave, what does that do to working environments? And that's what we've referenced as part of this work, that actually there is impact or potential impact. We've made an assumption from that research that actually if people are suspended or need to take sick leave, that will directly impact the provision of care. So I recognise out of those 4 areas that I talked about, that's probably the one that we need to do much more work on in terms of kind of making that connection. But I think there's enough sufficient wider research out there to suggest impact from workforce not being available for any number of reasons to support healthcare delivery has that detrimental impact. I'm going to bring Kevin in on there because we've talked a number of times around this.
Yeah, I think with always the challenge around evaluating interventions is how do you quantify things, because that's often the headline figures that people are interested in. 70% reduction is massive. And I think to try and quantify it at a local level, you would then be trying to look at what measures you have within that space, but you need lots of that. And I think certainly across one site, it probably will not be possible. So I think if we are looking at it at a more national level, then maybe there might be things perhaps that we could look at. But certainly, I think from a qualitative perspective is looking at that anecdotal information, stories that we can perhaps bring together. But one more point actually that we didn't explicitly measure over here, but I think it's something that comes up across a lot, is that it's not just about individuals going off sick, but what we don't know is how many of these 35 people who didn't go through a distress would have left the organization or would have left the service altogether. And the little clip, the audio clip from Anne's story earlier on, she took early retirement as because of what happened, and that is unfortunately quite common. So it's also thinking about that longer term impact of individuals staying in the workforce as well, because you have individuals who almost in the best case maybe choose to work in a different organization but still stay in healthcare, but actually often being signed off sick for long periods of time and exiting the workforce, whether it's the healthcare workforce or exiting the workforce altogether. And then there's the associated costs from an economy perspective, but also from a patient care perspective, because again, we're not only losing individuals, so numbers of people working, but as Andrew alluded to earlier on, is that experience and expertise of encouraging peers, but new members of staff coming to the system and losing the experience and expertise also will have a massive impact on patient care.
Yeah, absolutely. So, opportunities for further research once you guys get access to larger amounts of data would be great. It always, is important to connect with what is important for the organisation. Dollars always or pounds makes sense, right, for most organisations. But in healthcare, patient safety is obviously really important as well. So, yeah, it'd be great to see some more data around that for sure.
So, what action would you love to see as a result of people reading the work that you've done in this project?
Okay, if I could pick up that one. So 2 areas that I'd really like to see. So first, that organisations consider the impact of their processes on staff. I don't think we've done enough in that area to really link impact of a process to the effects on the employee and to the system. So, and again, that focus on avoidable employee harm gives the opportunity for that to take place. I think the second, I'd really call on HR colleagues, the profession, the academic research around HR management processes to almost own this work more, so that actually that they almost champion the change in approach to running disciplinary processes. I mentioned at the top of the call that actually there's very literature out there. So actually really calling on HR colleagues and the profession and the academic base to say we are making the case that this is causing harm, significant harm to individuals and also to organisations. How can you as a profession come on board with this and actually be a key part to the change that we need to see?
Yeah, an important point there, I think. A lot of the time we talk about, who owns psychosocial safety. And we talk about the distinction between like a process owner, a risk owner, and a control owner. But I guess in this case, it's sort of the investigation process is actually the cause of the harm in that case. So it actually almost all of it. So the risk owner, the control owner, and the process owner all sits typically in that HR domain. So there's a strong case to be made for HR taking ownership of this one for sure.
So, guys, it's been a really fascinating discussion with you both. There is, as I mentioned before we started recording, a lot of interest in Australia around psychosocial investigations at the moment. So, really great to hear this really relevant research regarding, the role of investigations in maybe causing unintended consequences on employee health, and that there are ways to consider your own processes and make sure that they are more health promoting and protects people from unintended harm. Um, One of the questions that we like to ask our guests at this stage of the podcast is, what are your hopes for the future of workplace mental health? I can't remember your answer last time, Kevin. I'm not sure if it's changed in a couple of years, but maybe if I could just get a few words from both of you about what are your hopes for the future?
I don't remember what I said last time either, so I'm just wondering. It'd be interesting to go back and say, am I saying the same thing? But I think that what my hopes is actually we take more of that systems perspective, and that we try. And as I kind of said at the start of this episode, that change is possible, and that what we are trying to do is to create a better version of what we have now than we had before. And we are not going to fix everything. It's never going to be perfect. But what we should be doing is trying and working towards being better than what we were before.
I think to add to that, that actually that's let's start again. I think to add to that organisations need to see that the issue is not the individual, that it is often their processes. So actually, if an individual is going through a process like the disciplinary process, and there is high trauma, high distress, high anxiety, it's often been kind of reflected on, well, that was how the individual managed that experience. Actually, the onus is on the organisation to deliver a process in a much more informed and compassionate and people-centric way. So I think from this work, if organisations own that as their responsibility, rather than laying it at the foot of the employee in terms of how they responded to the process, I would see that as a major change.
All right, and last question of the day for you both. Do you have words of advice for listeners who want to work in the field of psychological health and safety?
Well, if I actually use Andrew as an example, so I'm putting Andrew on the spot over here, is to basically say that whatever your background, your experience, it is possible to do something, because as we've talked about today, that health and safety, staff well-being space actually is so broad. We are talking about well-run organizations and well-run systems, and wherever you fit within that structure, there is something that you can do, whether it's an individual level to say, how can I create my workplaces a little bit better, my work environment, or what can I contribute to make this a better working organizational system for everyone else within that.
I think to add to that, really just to encourage colleagues to break out of their silos. So for us as an organisation, this was the first time that employee wellbeing formally worked with HR to address an issue. I kind of feel a bit embarrassed about that. How did it take this long to get to that point? And then actually both sides of this project said that the project wouldn't have been successful without the other partner within it. So actually, how do teams find a way of working together, harness the best expertise across those teams and bring it together for the goods of the employee and also the organisation?
Wonderful advice from both of you. Thank you.
Well, gents, it's been great having both of you on the podcast to talk to this topic. I think our listeners are going to get a lot of value out of this one. And beyond just, what is the harm that might be caused by psychosocial investigations within healthcare? I think what you've talked about is far broader than that in terms of good methodology in investigating any systemic issue within an organisation that has downstream implications for employee health and wellbeing. As well as, how could this kind of intervention be translated across any kind of organisation or any industry. So thanks for sharing the research, guys. We'll be sure to put clips to the research and some other related articles, and including Anne's story as well, a link to that video. The audio for those that are interested in checking that out. So thank you to you both.
Thank you.
Thank you for having us. And if anyone's got any questions, feel free to reach out to either one of us.
Great. Thanks, Kevin. So, listeners, that brings us to the end of this episode. Remember, we do record these over video with our guests. So if you do want to catch the video, maybe not of this particular podcast, if you made it all the way to the end of this one, but maybe of other ones, go to the FlourishDX YouTube page. We also share snippets of these episodes with our viewers on the FlourishDX LinkedIn page. So head over there for lots of nuggets of gold. And you'll find that Joelle and myself, and obviously Kevin and Andrew, are over on LinkedIn as well. So it's a good place to get in contact if you want to continue the conversation. But that's it for today. We'll catch you next episode.
You've been listening to the Psych Health and Safety podcast. To stay up to date with the latest on psychological injury prevention, follow FlourishDX on LinkedIn and subscribe to the Psych Health and Safety podcast at www.psychealthandsafety.com.